Welcome to MFC's online program. So this is the 7th in the series of 9 program. So today we are discussing right to health care. So we have two speakers. I'm here to introduce both of them and to just overall coordinate the program. My name is Jagadishan. So Abhay Shukla, I think many of you know Abhay, but still it's my responsibility to say a few words about him. He is a well-known public health physician who has been working in the area of health issues in collaboration with people's health movements and grassroots NGOs. He is the national co-convener of Jan Swasthya Abhay, and he has earlier worked on areas like developing community-based monitoring and planning, and also in different areas of patients' right movements and social regulation of private sector, developing the methods of universal healthcare coverage. And I remember that occasion when Abhay, you were here along with Sundar Raman, Sridham Reddy, and Renu Ghana.
Yeah.
Iqbal sir would be remembering that occasion when we had the mid program evaluation of the Ardram phase 1, and we had extensive field work, and I just remember that occasion. So I think before going to Abhay for the presentation, I will just introduce Chaya too, since these two topics are related, and I need not interfere in between. So Abhay would be speaking basically universal healthcare, movement for right to healthcare campaign, ongoing strategies, and newer directions. So Abhay's topic would be general, and Chaya would be speaking on Rajasthan's experience. So now let me introduce Chaya. She is also a co-convener of co-convener at the national level of JSA Jan Swasthya Abhiyan, and state coordinator of Jan Swasthya Abhiyan Rajasthan. And she is also director of Prayas, an organization working around issues related to public health and social issues. She is with a rural development background, and she has ample experience in rural areas of Rajasthan, community level, especially tribal areas and rural areas, and working on issues like health, nutrition, access to healthcare, and all. And she was active in free medicine campaign of Rajasthan, and against the privatization of public healthcare institution campaign of Rajasthan, and also played very critical role in Right to Health Act of Rajasthan. So now we shall go to both the speakers, and I discussed with Abhay and Chaya that we'll have half an hour presentation by both the presenters, and afterwards we will have around half an hour discussion. We can go up to even 9:15, 9:20 also. So, but since two speakers are there, we'll have some time constraints, and participants, of course, you can put up your query or your comments in the chat box, and we will discuss them towards the end, and also we will take up the queries and other discussions. So over to you, Abhay.
Okay, thanks a lot. So thanks to the entire, MFC group, and especially the MFC Kerala group, it's really great to see the activity before the, the mid-annual meet and all the series of pre-conference sessions which are going on. So I'm really privileged to participate in this process. And when Dr. Jagdishan asked me to speak, I was actually in a bit of a quandary about what I should speak about. It's a huge topic. And, we had recently in the beginning of this year, a full 2-day national workshop just on right to healthcare. So there are so many things to be talked about. So I'll just be touching on some of the experiences, some of the key ideas and frameworks, and also some of the strategies and emerging or potential directions, so that it's not just an academic discussion, but of course it needs to be a conceptually somewhat grounded discussion, but linking with our practical kind of campaigns and activities which we can do around the right to healthcare. So first of all, I'll just mention what
We
I'll
can
be
see
talking.
we can see the slides.
Some confusion or maybe some areas of clarity. Okay, thanks. Yeah. And then I'll be talking about India's mixed healthcare system briefly, which make things more complicated. So when we ask for the right to healthcare, we need to understand what is the nature of our health system, in which context we are demanding this. And then I'll be talking about the right to public healthcare services more specifically, and the elements of this right to public healthcare. And then a little bit about rights related to the private healthcare sector. And then some lessons which have emerged so far from, in my understanding, from the movement around right to healthcare and health in India until now, and how they can help us to move ahead. So first of all, what is the right to health? And in general, what is the what kind of right is this? So what is a right? A right is a socially recognized and regulated claim. It may be legally established or it may not be legally established, but it is at least at the level of society. It's a claim which is widely recognized and which is considered to be important. And when we talk about the right to health, it's not a right to be healthy because our being healthy depends on many factors, some of which are under the control of the state and the government from which we can demand rights, and some other factors like individual, body constitution or susceptibility, or the way in which our lifestyle, our behavior, our diet. There's so many things which are, not directly addressed by the state. So we cannot demand that we want to be healthy, but what we can demand is that we need to have the adequate conditions and services which are required for being healthy. So as WHO says, that the right to health is basically, it's a socially recognized claim to a set of collective arrangements, to a set of social arrangements, which include some norms, laws, an enabling environment, certain systems, and these together ensure the enjoyment of this right. So it's not just a legal, process. It has a social dimension, it has a health systems dimension, and these together. And when we talk about the right to health, we're actually talking about two sets of rights. One is the right to health care, which is the services and the care which is provided by the health system and or the healthcare system. And the second part is the right to determinants of health, which is all the other conditions like safe drinking water, adequate sanitation, adequate nutrition, and food security, healthy environmental conditions, etc., which all also are very important for health. So these are the two components that we are talking about when we talk about the right to health. Today, I'll be mostly talking about the right to health care, which is an important subset of the right to health. And, I'll be focusing on that. So now let us be clear about when we are talking about health rights, what are the three sets of health rights that we can talk about? The first, which often when we talk about the right to healthcare, we are talking about the right to public healthcare services. Because healthcare services which are delivered by the government through PHCs or public hospitals or outreach services like vaccination, etc., these are, publicly delivered, and there is at a certain level, even though it is not a constitutional right, but there's a certain level of strong entitlement which we have because these are based on public funding. These are based on, taxation, and these are supported by citizens of the country. So usually what we talk about when we talk about the right to healthcare, we're usually talking about the right to public healthcare services. But there is a broader range when we talk about the right to healthcare in general. When we say that everybody should get comprehensive healthcare from primary to secondary to tertiary levels, all sections of the population, poor, middle class, rich, everybody, then at least in a country like India, we will need to involve private providers also. Because not the entire spectrum of healthcare for everyone in the current situation at last cannot be given just by the public health system. So then we are talking about a wider range of actors and a wider range of entitlements, which amounts to the right to health care. And the third level is, of course, as I already mentioned, that when we are talking about the right to health, we're talking about not just the right to health care, but also the right to various social determinants of health. So these are three levels which we should distinguish between. Perhaps this may be clear to many of us, but in case it is not clear, and because my next slide is trying to further clarify what these three levels of frameworks. So the first level, A, is right to public healthcare services. The second level is right to comprehensive healthcare, which includes not just public health services, but also some kind of section of private healthcare. And the third is the right to health. So right to public healthcare services, who are these rights applicable to? People who go to public health facilities. Right to healthcare, on the other hand, deals with the entire population who requires healthcare. And right to health, it deals with everybody, because the right to health affects everyone. So, and similarly, if you're talking about legal provisions, if you want legal provisions for right to public healthcare services, we would ask for a right to, a right to public healthcare act, or a basic right to healthcare act, which mainly deals with the kinds of services which people can expect and demand from the public health system. But when we talk about the right to healthcare as a comprehensive right, then we're talking about something broader. We're actually talking about a universal healthcare system, which includes not just public healthcare providers, but also, at least in the context of India, some section of private providers who will provide all the services which people require. And when we talk about the right to health, we're going even one level above, where we require this kind of a right to healthcare and also, social determinants of health. No right can be fulfilled unless there's a system to fulfill that right. This is very important. So otherwise, it'll just remain a legal right on paper. So we need certain systemic provisions for fulfilling each of these levels of health entitlements, whether it is a right to public healthcare services, or it's a broader right to healthcare, or it is the right to health. So I hope this is reasonably clear. Now, what makes the situation a little complex in India is because we have a mixed healthcare system. And we have something which is called the mixed health system syndrome, which means that when we have a large private healthcare sector, about 70% of provisioning is from private healthcare. We also have a significant infrastructure of the public health system, and both of these, have their own areas of service delivery, but they also interact with each other. And now we also have health insurance schemes in many states of the country. We have a national scheme called, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. We have many PPPs where public and private are mixed. So this gives rise to a complex situation. And it's in this situation that we have to actually be very clear about what we are actually asking for when we are asking for the right to healthcare. Are we asking for services from the public health system, or are we asking for a larger, universal kind of system, which includes both the public health system and private provisioning? And to complicate matters further, the aspirations of people and the spaces where they can demand rights are not always the same. So today, if you go to any community, generally speaking, and ask people, what kind of services would you like? They would say, we should get, free services in private hospitals or something like that. Or at least there's a perception that private hospitals are better. This may not be true in some places, but in many places, that is the kind of situation. So the places where we can demand rights and what actually people want, or at least in their current state of thinking, are not always the same. So that also leads to a certain kind of tension. And this is because of our mixed healthcare system. Now, let's first start with demanding public healthcare services, which is where a lot of work has been done in the health movement until now. And this involves a cycle of change, which I'll talk about. But we start with local issues. So the PHC is not functioning properly. People are not getting medicines. There is ambulance is not working. The doctor doesn't come in time or is not always available, etc., etc. The ANM is not going to the village for giving immunization regularly, whatever it is. So most of such processes start with local issues, raising local demands and so on. Now, these are very important, these local demands, because that is the basis for demanding, rights from the public system. But just raising these demands does not lead to a major change in the delivery system. So what may happen is that people can demand some things. Maybe due to some local pressure, some things will improve. but the basic staffing, supply of medicines, infrastructure, which comes from the state level and national level, that may not change very much, only if we are limited to raising local issues. And that is why when we're demanding the right to public health care, in any sustained such process, we will need to combine local actions with also campaigns for health system reform, health system improvements, policy level improvements, which will lead to the public health system functioning better. And there are so many examples in Jan Swasthya Abhiyan where we have probably started from local level demands, but tried to raise these at the policy level also in various states. So I'll just give two examples here of how we have actually tried to operationalize right to public healthcare services. The first is community-based monitoring of health services, which is a process which took place across at least 9 states of India as part of the National Rural Health Mission to begin with. Later on, as part of the National Health Mission, it's still going on in some form, but definitely not in its earlier form. So I'll only be talking about the Maharashtra experience, but it's kind of probably indicative of also what has been done in other states to some extent. And this process, how do you operationalize the right to public healthcare services in a real life situation? This is a good example of that. So the first starting point is community awareness. Unless people know what their rights are, what their entitlements are, no process for health rights or healthcare rights is going to be particularly effective. The second is community assessment, gathering information about what is the actual current situation. Is the PHC functioning properly? Are immunization sessions going on? Is the ambulance working? What is happening about medicines availability? So all these things involve community assessment, and that has been a second step. The third is, which is highly desirable, is to have some kind of multi-stakeholder committees or bodies where people can raise these issues. And as part of the community monitoring process, we reformed these committees, we expanded them, we activated them, because without dialogue, rights are not achieved. Because the people who are not in power, but who actually are the claim holders, they raise the questions, and the people who are in power, who are the duty bearers, they have to respond. So when there's a dialogue between the claim holders and the duty bearers, and that's a meaningful dialogue, then actually rights are more likely to be achieved. And the second very important platform which we have used is of Jan Sunwais or public hearings, or Jan Samvads or public dialogues. And in Maharashtra itself, as part of the community monitoring process, we have organized more than 700 such public hearings across the state. And this has been, we used to call them engines of change, because that is when the difficult dialogues take place, when hundreds of people gather, they start raising questions, they start presenting their testimonies of denial of healthcare. And that is when, the system is kind of pushed into responding. And along with that, of course, we have also had participatory audits of Rogi Kalyan Samiti funds, of local, public health funds. And are they being used properly? If not, then how should they be used in a better way, which is linked with decentralized health planning. So usually, so it is highly preferable to combine community-based monitoring also with participatory health planning, so that, not only we are raising the questions, but we are also proposing the solutions or how this situation can improve. So this is one example of how from very localized raising of, demands and demanding health rights from the public health system, a broader social accountability framework was created or has been created. A second example is from Tamil Nadu, where there have been, since 2021 onwards, there have been these series of district health assemblies. And these are quite interesting kind of events where basically these have taken place in 3 rounds until now, as I understand, covering practically all the districts of Tamil Nadu. And each of these district health assemblies, they are preceded by block level or taluka level, health meetings or health dialogues. And in the health assembly, the health officials are there, the MP, the MLAs, the panchayat members, civil society groups, frontline health workers, and people from the community. They're all involved, and they raise issues of concern which have been documented. at the block level, at the village level and PHC level. And then these issues are raised one by one, and then the officials need to respond and need to propose solutions and take some kind of action. And many of the issues have been related to healthcare infrastructure, staffing, equipment, delivery of services, also in some cases inequities, where Dalit communities or other sections may not have been receiving the services. And these have provided an interesting major platform. And they have been followed also by some state level health assemblies, which have been attended by the chief minister of the state, by the health minister, and so on. So the important point is that when we can start by raising local level demands, but if we are able to put in place such more, multi-level social accountability and rights claiming mechanisms, then the process becomes much more effective, because often issues may be raised at the local level, but they may not be resolved at the local level. And then we have to go to the block level, district level, perhaps even state level. And that's what I'm calling a cycle of change. To the extent that we're able to put in place such a cycle of change, which goes from local to district and state, and then again comes back from district and state with the orders to implement those at the local level, that is when, there's a greater likelihood that we can realize these healthcare rights. And here I just flag, because this is something which we can think about. Spaces for accountability are shrinking today in our country, in all sectors and also in the health sector. Today, we do not have the kind of space for community monitoring, which we had about a decade back. But there are some spaces which are, even if they are small, they're still significant. And one such space is the Jan Arogya Samiti. As you know, that each health and wellness center at the sub-center level or the PHC level is supposed to have a Jan Arogya Samiti. But in most places, these spaces have not been occupied or they have not been activated. So one experience from Maharashtra has been where Sati and some of the partner organizations occupied these Jan Arogya Samitis, activated them, trained the members, the panchayat members, the local women's groups, and so on, and started visiting the health and wellness center. The members of the Jan Arogya Samiti doing monitoring visits, doing some kind of public audit, raising the issues, then in the Jan Arogya Samiti, asking the officials to take actions, also asking for better utilization of the funds which are available. And then through this activation of the panchayat members, dialogue with the medical officers, many small issues have been addressed. These are relatively recent processes in the last 2-3 years. And, water supply, electricity, furniture, facilities for patients and the staff. And also, and this has led to a significant increase in utilization of health and wellness centers, especially for treatment of NCDs like high blood pressure and diabetes. So this is a space which is available across the country. It may not everywhere be very functional, but if efforts are made, then at least there is some experience that it can be, quite effective. So now these social accountability process and claiming of health rights, as I already mentioned, at the local level is not sufficient. We have to raise these also at the state level. And if you can see this diagram, that there's a kind of a reinforcing cycle between health system reform and social accountability. When the system is ready to reform itself, it's more open to social accountability processes also. And when there is social accountability demands, that can actually fuel or push for health system reform. So each one reinforces the other. And this, of course, depends on the larger political situation. Sometimes there are spaces for this, sometimes there are very little space for this. So, for example, the JSA series of public hearings with the National Human Rights Commission, which we organized in 2004, it raised the demand of health rights across the country, although there was not much immediate action. But after that, with the change of government at the national level, launching of the NRHM in 2005, then there was a process of public health system reform, which was initiated with some level of effectiveness. And within that process, community-based monitoring got institutionalized as a process for which can enable people to claim their health rights. So claiming of rights leads to reform, and the reform process itself led to strengthening of the claiming of rights. And this is, of course, the the entire series of public hearings which we organized, which opened up this kind of space with a change in the government and various other factors operating. So when we talk about implementation of health rights, right to healthcare, it involves at least 4 different elements coming together from different aspects of society. So there is a social demand to claim the health rights. There is some health system capacity and there is some basically ability of the health system to ensure, access with equity. There's some kind of political will. It may be at the local level through panchayats. It may be at the state level. It may be at the national level. That depends on the situation. And then in addition to these three, at least in some situations, there may also be a legal provision. So to ensure healthcare rights or right to healthcare does not always require a legal provision, but if there is a legal provision, that will definitely help, enable the achievement of right to healthcare. So all these four kinds of processes, ideally, to the extent possible, should converge or should be complement each other if we want to implement the right to healthcare. Or to put this in a little different way, at a different level, what are the 5 core components of the right to public healthcare? As far as the, what are the kind of, actions that are required. So these are all given in the Jan Swasthya Abhiyan People's Manifesto, which we developed before the Lok Sabha elections. And I just call it ABCDE for simplicity. Don't take it too literally, but just so that we can remember it easily. So A is Act, a Right to Healthcare Act. B is budget. Without the budget, it's difficult to ensure that those rights are delivered. C is community accountability mechanisms, whether it is social audit or community-based monitoring or participatory committees. D is doctors and drugs, which means basically human power and medicines, which are extremely important for the entire system to be able to deliver the services which are demanded through the rights. And E is the expansion of public health services according to the population needs to ensure that in rural areas, urban areas, tribal areas, everywhere, there are sufficient number of facilities that are available. So if we have A, B, C, D, and E, all 5 in place, there's a much better situation where the right to healthcare can actually be delivered. Of course, we don't always have all of these in an ideal situation, but at least this is good to keep in mind. When we talk about the right to healthcare, we have to specifically keep in mind many vulnerable sections, deprived sections of the population, and also special kinds of situations. Because those who have less in life need more in rights. So those sections of society who are discriminated against, who are marginalized, who are deprived economically, socially, they definitely have they have additional, need for certain kinds of services also, and they also need to be given special attention. Then only we can achieve the right to healthcare or the right to health. So people living with HIV/AIDS, people with mental health issues, and of course, women, children, Adivasis, Dalits, Muslim communities, for a variety of reasons, they have special health needs. They have they face certain kinds of marginalization or discrimination. They need to, we need to specifically make special provisions for them to achieve the right to healthcare. And here I'll just very briefly flag also that a non-solution regarding right to healthcare is the health insurance schemes which we have in our country. And these arrangements, they actually, generally speaking, do not usually fulfill the right to healthcare, but we can discuss that separately. A few quick, points about a recent campaign on right to healthcare, which we have had in Maharashtra, starting with the Nanded hospital deaths incident, which took place last year in October in one district of Maharashtra. We organized a series of district health rights assemblies across different parts of the state. And we developed a 10-point right to healthcare agenda and organized a state level assembly where we invited, before the Lok Sabha election, we invited all the opposition parties representatives and they attended, and we presented to them this entire, agenda. And now in Maharashtra, we're having the Vidhan Sabha elections. And now we are developing also some specific health manifestos related to Adivasis, Safai Karmcharis, Muslim women, and also district level health plans or health manifestos, which we'll be sharing with the political parties. So this is basically about the right to healthcare in context of public health services. A few quick points about right to healthcare regarding the private healthcare sector. As you know, during COVID, across the country and also in Maharashtra, there was huge amount of overcharging and other violation of rights in private hospitals. In this context, Jan Arogya Abhiyan organized a public hearing. We documented complaints of overcharging. In a few places, there were anger assemblies or Santap Sabhas, where COVID widows or women who have lost their husband to COVID, they came with their complaints of huge overcharging, bills of 20 lakhs, 25 lakhs from private hospitals for COVID care, in which their husband has died, and now they are, faced with these huge bills. So because of this entire campaign, the Maharashtra government was kind of pushed into conducting an audit of private hospital bills. So the point is, we can demand health rights in certain situations, even from private hospitals. Because of this entire audit process, in various parts of Maharashtra, in 63 of cases of these complaints, people received refunds from the private hospital, average of more than 25,000 rupees each. And, more than 16 lakh rupees were refunded to people. And after COVID, now we have continued this process in at least some parts of Maharashtra, in certain cities where certain legal provisions for display of patients' rights charter, display of rates of the hospital is supposed to legally, actually mandatory, but it's not happening on the ground. And grievance redressal cells are supposed to be formed in every district and every city. So we are basically now, there is a campaign to ensure that these rights related to private hospitals should also be implemented. And incidentally, the Patients' Rights Charter is something which is applicable to the entire country, not just to Maharashtra. So I'll come to that. Another interesting example of how you can operationalize, how the government, if it wants to, it can at least help to operationalize rights in context of private hospitals, is from West Bengal, where they not only have a Clinical Establishment Act and rules, but they also put in place a full commission with full-time staff of about 35-40 officials to ensure that private hospitals, if whatever complaints are raised, those are actually addressed. And this commission has an interesting kind of track record in which they call the hospital, they call the private hospital owners, they call the patient, and then they have hearings. And within 1 month, they dispose of these complaints, and they've dealt with more than 1,500 cases regarding private hospitals in West Bengal. So this is an interesting example. And now, as I said, that not only at the local level, but we also need to raise issues at the national level. So we have a public interest litigation going on, which has been filed by Jan Swasthya Abhiyan in the Supreme Court of India. And the hearings on this have started. And here we are asking for national standardization of rates in private hospitals according to the Clinical Establishments Act, and also implementation of patients' rights. The Patients' Rights Charter, which has been issued by the Union Health Ministry based on NHRC's initial draft, is very important because this deals with a whole range of rights which we have as patients in both public and private hospitals everywhere. So I'm not going into the details. Perhaps you know about these rights already, but this is something that we can demand as a strategy, another practical demand which we can raise wherever possible, because this is applicable to the entire country. And especially in context of the PL, we need to actually demand that any private hospital should display the Patients' Rights Charter and should observe at least basic patients' rights. So gross violations like detaining the dead body of the patient in a private hospital to force the relatives to pay a higher bill amount, or asking the patient to buy medicines only from the hospital's own pharmacy. These are all actually illegal, and also they are completely, they are violations of the Patients' Rights Charter. So we should raise awareness about this and demand this. So finally, coming to the conclusion, this is a time where we need a health system change, learning from COVID. And these are 6 lessons which I would say we can take back as our direction for right to healthcare. Public health services are the lifeline of societies. They must be strengthened. Frontline health workers are critical. It's the ASHAs, the ANMs, the nurses, the junior doctors who must be protected. They protect us. We must protect them. Privatization of healthcare, as we have seen, it failed during the COVID pandemic, and it needs to be abandoned as a policy. On the other hand, states must effectively regulate private hospitals. And as an immediate demand, whichever state we may be in, we should demand the right to public healthcare services as an immediate demand, and also move towards a system for comprehensive right to healthcare based on both expanded and strengthened public health services and also regulated private providers, so that everyone has a right to healthcare. And these are some of the other lessons from the COVID pandemic, which I will not go into detail, but the pandemic taught us a lot of things about how people can come together in an emergency situation, how we can expand the idea of public. The public is not just public officials. It's also panchayat members, volunteers, frontline health workers. These are all part of what we can call an expanded public. and also mobilization of medical victims, promoting a more interventionist form of regulation, and using the criteria of publicness to look at the entire health system, including health insurance schemes, public-private partnerships, and universal healthcare. So I'll conclude by saying that basically we need to basically bring right to health and right to healthcare on the political agenda, and which we did try to do as JSA before the Lok Sabha elections. And I would urge all of you who have not read the Jan Swasthya Abhiyan manifesto, the recent manifesto, to definitely access it. And we need to see how we can make right to health and right to healthcare a political agenda. That would be the way forward for achieving this in every state and every place in our country. Thank you.
Thank you, Abhay. Very comprehensive and very practically oriented presentation, and bringing in different type of activities done by JSA, and including Tamil Nadu and West Bengal's experience. And so thank you so much, Abhay. And this will lead to very many further interventions and in the country, I suppose. And now it is time to go to Chaya. Chaya will give a detailed elaboration of what happened maybe for last 5 or 6 years in Rajasthan, maybe even more than that. And so Chaya, you can take half an hour from now on, and afterwards we'll continue the discussion. So over to Chaya.
Thank you, Dr. Jagdishan. Just making sure, am I audible?
Yeah, sure, audible.
Okay. Thanks. And thanks for this opportunity to share about the Right to Health campaign of Rajasthan. And also congratulations to everyone from MFC on the completion of 50 years. I think Abhay very comprehensively has covered, what right to health means and what could be the different approaches to claiming right to health, and what different roles can the community or the civil society or the governments can play in ensuring it. What I'm going to speak about is largely based on the experience of Right to Health campaign of Rajasthan. And I would begin by saying, many of us in the field of health and medicines, we at times feel that, laws are very peripheral, or we do not really see them as, as an important tool towards right to health. And we although do not realize that, laws and acts have been very critically important in ensuring right to health. And there are already a number of acts and laws which govern and protect health rights in different ways, directly or indirectly. We have laws and acts which directly are aimed at, healthcare services. And then there are acts and laws which are largely around the social determinants of health, say, for example, the Right to Food Act or the Right to Education Act, and so on. And I think it's very important for us to recognize and acknowledge the legal determinants of health as another approach to, claiming health rights. And I think in India, we haven't really been able to tap, the laws and acts in claiming health rights as effectively as we should have done. It still remains a largely untapped resource. And I think what we tried to do in Rajasthan was to make use of this tool, the tool of law, to ensure that it strengthens public healthcare system, and that it enhances and augments the commitment of the government towards ensuring that health rights are protected and people receive free quality healthcare services from public healthcare facilities without going through the huge out-of-pocket expenditure which they do, which further pushes them into poverty and impoverishment. And with that idea in mind, the campaign for Right to Health Act began in Rajasthan sometime around 2016 and 17, although it was something which we had been deliberating on and speaking about since a long time, but it was in 2016-17 that the entire campaign picked up pace. And it was essentially because 2018 was the state assembly elections. And we thought that it was a very opportune time for us to push for such a law. And that's when we started, interacting with different parties, going and having meetings with them, essentially to ensure that they put this point into them election manifestos, that if they come to power, they'll come up with a Right to Health Act in the state. Obviously, not many political parties agreed with us and couldn't really understand the significance of it, but a few political parties did increase, including the Congress and CPIM, and they did put it into their manifesto. And subsequently, Congress party won and came to power. And we thought that it was a very, fruitful thing to happen for to us as a matter of, a campaign around Right to Health Act. And that's when immediately, as soon as the Congress party came into power, we to put pressure on them to walk the talk now, basically. We told them that you have already put into your manifesto, and it's time now that you start working on the bill and come up with it as soon as possible. And Jan Swasthya Abhiyan, Rajasthan was the first group in the state, and in fact, probably the only group in the state to come up with a blueprint of the bill and share it with the government, just to make it easier for them to further work on the bill which was to be tabled at the Legislative Assembly. And I think it was in 2019, things took up pace very fast. And in fact, we felt that the government was acting quite efficiently in order to build up the bill. And they were also very open to the participation of the civil society organizations, including Jan Swasthya Abhiyan and other organizations and networks working around health, and to including them in developing strong bill. And we had a couple of meetings and consultations jointly organized by the government and Jan Swasthya Abhiyan to ensure that the bill comes about soon and is tabled in the Legislative Assembly soon. So the first year, the year 2019, we saw there was very good kind of progress with regard to coming up with the act. In fact, the government also constituted a drafting committee, of which, Abhay was also a member, Dr. Narendra Gupta was a member, Dr. Pavitra Mohan, most of you might know him. He was also a member, and they all worked together with the government officials and public health doctors to come up with a robust draft of the bill. But then all of a sudden, COVID came about, and for almost 2 years, 2020 and 21, everything almost came to a halt, and there wasn't much progress. But what followed after it, in the year 2022, when we again started to put pressure on the government, saying that the COVID has now calmed down and you must again start working to come up with a draft of the bill. The situation had changed to a great extent. The kind of openness which was there initially to involving public health, civil society organizations in the drafting of the bill, in the development of the bill, we didn't see it again. So everything was happening in a very coveted manner. And, everything was happening internally within the health system. And we didn't really know what was happening with the draft that the initial committee, which was constituted, it developed, and what kind of changes were being made into it. And the involvement of civil society organization was very negligible. It was in March 2022 that the government came up with the first draft of the bill. And it was put up on the public domain on the website of the health department for general comments and suggestions. So very interestingly, the act which you see now, the Rajasthan Right to Health Act, which you see now is in fact is the third version of the draft. So there have been several changes in the draft, and a lot of it happened as a result of the pressure and the resistance by the doctors' fraternity, the agitation and the resistance, against the act. So the draft, which was there in March 2022, it was further revised, and then the first draft of the bill was tabled in September, and there was huge agitation by the doctors against the bill, which was tabled in the assembly, and it was immediately forwarded to a select committee, which was constituted in order to look into the concerns of the agitating doctors. And then a final draft, after incorporating their demands and suggestions, was tabled in March 2023. And that's why, when you look at the act, you would see that it's called Rajasthan Right to Health Act 2022, because it was first tabled in 2022, but it got passed at the Legislative Assembly only in March 2023. I'm kind of often asked, what do you feel about the act? Do you think it's a robust act? It's a strong act? How do you perceive it? And I think it's a very tricky question, because when it comes to acts and laws, we have to recognize and acknowledge the fact that there are different parties to it, and different parties would have different interests, and every party would want that their interests are safeguarded, that their interests are not harmed through the law or the act. And if you ask me, because we are health activists and we largely look at laws or policies through the perspective of the patients or the most vulnerable population, if you ask me, I would say it's strong in several ways, but it's also weak in a plenty of ways. So I would say it's a partially strong act, but it with its own lacuna and flaws. But then none of the acts which come about are perfect, and all of them kind of have their own, gaps and lacuna and flaws. And I think we have to be considerate about it, that this act which has come about is significant in itself, and it's significant for several reasons. One, I would say, is that it's an act for the first time which is titled Right to Health Act. We have several public health acts in the country in different states. We also have other health-related acts and laws, but none of them explicitly call themselves a Right to Health Act. But I think it's significant for a reason, because it's a legal document, and it has been brought about by a government which was under rule at that time. And for a leadership to commit to something which is around right to health in itself is significant, and that needs to be acknowledged. However, again, like Abhay said, there can be different kind of rights. There can be patients' rights, there can be right to health at large, which also covers social determinants. And then the right to health care. So the name of the act, the Rajasthan's Act, is somewhat of a misnomer, because while it's titled Right to Health Act, it essentially largely deals with healthcare services, and that too in the public healthcare sector. So it's more about public healthcare services and public health systems strengthening. However, there has been a very wrong narrative about the act, which was circulated essentially by the agitating doctors, saying that this act would kind of, hamper the private healthcare sector and completely demolish the private healthcare sector in the state, and is against private healthcare, which was completely wrong, because the act, if you read it, if you go through it, you would find that 95% of it, I would say, focuses on public healthcare sector, and there's just one clause which deals with emergency treatment, which also refers to private healthcare facilities. Apart from that, all the obligations of the government, if you read in the act, those are around strengthening public healthcare system. It calls for greater budget, adequate budget for healthcare system, streamlining the HR policy, transfer policy, and then it narrates entire range of patients' rights, which Abhay also talked about, the National Human Rights Commission's Charter for Patients' Rights. So every point in that charter has essentially been incorporated into the act, giving it a legal framework. So it largely deals with healthcare, public healthcare, but there has been a narrative that it was going to impact private healthcare providers and private healthcare sector in the state, which was a very misleading narrative. Now, I think it's also important for us to understand why did the doctors, and I'm not just saying, and I'm not just talking about private doctors, but why did the doctors at large had such a huge issue with this act? It's very important to understand it, because it also kind of tells us why the act hasn't really got implemented as of now in the state. The current status of the act is that the act has been passed and it stands as an act now, but it hasn't been implemented essentially because the rules of the act, which are very important for its implementation, no act can be implemented without its rules. So the rules haven't been framed. And it also, why the rules haven't been framed, this is again a very tricky question. It also brings me back to the point that, while the previous government, which came up with the act, perhaps had the intent of bringing about the act, but didn't really have any intent to implement it, because they had enough of time, after the bill was passed in March 2023, to probably frame the rules and initiate its implementation to some extent, but they kept avoiding it. In July 2023, they had in fact also constituted a committee to work on the rules of the act, but nothing came out of it, and the rules never came about. And currently, since the government has changed, now at that time it was the Congress government which brought about the act, now it's the BJP, and as has been a general tendency, when a new government or a new political party takes over, there's a general tendency to undermine the acts or the programs, the schemes brought about by the previous government, and to neglect them. And that's what's happening in Rajasthan as of now. The BJP government doesn't seem to be keen at working on the rules of the act. And even just some days back, when the state budget was being presented, we didn't hear anything about the Right to Health Act in the entire budget speech, although the budget allocation for health has been increased. So Rajasthan until last year was spending somewhere around 7.4% of its total budget on health, which the government now claims is being increased to 8.2%. However, we compare this spending in terms of state GDP, it's not really very high. It comes to about 1.2% of the state GDP itself. But I guess, one of the reasons why the act also, the governments, the previous government and also the current government, they have been reluctant about implementing the act. It's probably also keeping into account the kind of agitation and resistance it faced at the hands of the doctors. And I wouldn't say it was only the private doctors or the private healthcare sector which was against the act, because the government doctors, they never really spoke in support of it. They never came out in support of the act. So probably there was a tacit, opposition to the act, even among the public healthcare doctors, government doctors, but they didn't really come out very openly about it. But also, what was the major point of confrontation among the doctors and the government with regard to the act? If you read the articles or in the media, or if you speak to the doctors who were agitating, they kind of largely highlight this one clause of emergency treatment. And they say that it's largely because of that clause, that particular clause, that they were against the act. However, I don't really think so. And I have reasons for it. And one of the reasons is, if you look at the agitation or the campaign by the protesting doctors against the act, you would see that their slogan always since the beginning was "No to Right to Health Act, no to RTH." This has been their slogan since the beginning. And one of the things that they could have done otherwise, I mean, if they didn't have an issue with the entire act and only with that particular clause, they probably, during the negotiations with the government, which happened quite a lot, they could have asked for the removal of the clause rather than entirely going against the whole act. But they didn't do it. So their slogan since the beginning was "No to Right to Health." Now, even during some of the conversations of mine with the agitating doctors, when I would ask them why were they protesting, many of them would begin with this particular clause, saying how this clause was problematic and how it would hamper business or their profits or the way they function. But towards the end, most of these doctors would say, why do we even need a law for right to health? There are already so many laws and regulations around health and healthcare. Why do we need another act? And so it all came down to, we don't, to the fact that, doctors were largely against the entire law. Now, also bringing to the fact that the Rajasthan's Right to Health Act is heavily borrowed from the Public Health Act of Assam. If you read the Public Health Act of Assam 2010, there a lot of things you would find resemble the Rajasthan's Health Act clauses, resemble what's there in the Assam's Public Health Act. The other question that comes to my mind, if it was just the clause of emergency treatment, which was troubling the agitating doctors, the Assam's Health Act also had this clause. If you read the clause 4O in the Public Health Act of Assam, it also says that, all health facilities, government or private, should provide emergency treatment free for 24 hours to the patients. But we didn't really see that kind of hue and cry in Assam, when that particular act was passed. I mean, most of us didn't even realize that such an act has been passed. There was no interference of the IMA. There were no agitations, nothing. And Rajasthan's Health Act, like I said, is more or less similar to Assam's Health Act. So what was it which was actually troubling the agitating doctors? And for that, I tried to compare, some of the acts, Rajasthan, Assam, and also the latest Kerala's Public Health Act. And I found that, the Rajasthan's Health Act kind of puts a lot of emphasis on empowering the patients and provides a lot of power to the patients. And that is very evident right from the preamble of the act. And I just wanted to read out some of the phrases from the preamble. And the preamble of the Rajasthan's Right to Health, it talks about Article 40, it refers to Article 47 of the Constitution. It refers to Article 21 of the Constitution. It talks about free, accessible healthcare, equality, reduction in out-of-pocket expenditure, which we don't see in the Assam's Act or the Act of Kerala. And it also talks about, and there's a statement which says, Government of Rajasthan is committed to ensure that people's rights to health are realized. The most important stakeholders in fulfillment of right to health are the people themselves. This is in the preamble. And it says, therefore, people's participation is crucial and critical for realization of people's right to health services. So this is something which is very specific to Rajasthan's Right to Health Act, and we don't really see it, such kind of assertion and clarity with regard to, empowering people or patients in the Act, in the Assam's Act, or the Kerala's Act, which Kerala's Act is slightly different because it's largely about prevention and control of diseases rather than strengthening a healthcare infrastructure. Is anyone saying something? No. Okay.
No, nothing. You can continue. You can continue.
Okay.
Maybe somebody switched on the mic.
Okay. So the other thing, when I did a comparison of these three acts, I haven't really been able to study other public health acts, but Rajasthan, Assam, and Kerala, I felt that Rajasthan's Right to Health Act in some way was strongly rights-based, while the Assam's was also, but in comparison to that, the emphasis on rights was far more in the Rajasthan's Right to Health Act. None of the acts, like the Assam or the Kerala, they didn't talk about any kind of grievance redressal system, which is very specifically talked about in the Rajasthan's Right to Health Act. And that also makes it slightly different from the other acts. So it kind of outlines, how the grievance redressal system would look like. And there are also provisions of penalty into the act, which was not there in the Assam's Public Health Act. However, the Public Health Act of Kerala does have some provisions for penalties or fines, but those are not specific to healthcare providers, but those are largely, based on if anyone violates the rules which are essential to be followed to prevent diseases or to control disease outbreaks. So I think, some of the things which made doctors very uncomfortable about the Right to Health Act of Rajasthan was essentially how it kind of empowers patients and puts them into a very powerful position, where, they can complain if their rights are denied, or if the services are denied, or if any of the provisions under the Act are violated. And also the fact that, if the healthcare provider or the service provider is found guilty, there can be penalties imposed on them. So I think this entire narrative that the doctors only had an issue with the emergency treatment clause is not really true. It's the entire act, the entire law, which made doctors very uncomfortable, because probably they felt that, they would lose the kind of authority that they have over patients. And this might have kind of made them feel that this act is not in their favor or does not serve their interests. However, I mean, this act has its own gaps and lacunae, and a lot of it also came about as a result of the government succumbing to the pressure and the demands of the agitating doctors. So a lot of amendments which were made by the select committee into the draft bill were in order to appease the agitating doctors and to calm them down, because the agitation had gone on for more than 2 weeks, and the entire private healthcare sector of the state was shut, and the kind of pressure which was there from the IMA on the doctors to join the agitation, to shut down their services. And I know of instances where the healthcare providers were threatened, if they do not shut their services or their laboratories, there would be actions taken against them. So there was also this. I don't know. I mean, during the Public Health Act of Assam, which happened in 2010, I don't know how IMA, how much was it looking into these things, or how actively was it trying to ensure that, the profits or the interests of the private healthcare providers are not affected. But then again, like I said earlier, IMA is not just about private doctors. It also involves government doctors, and none of the government doctors came out in support of the act or spoke in support of the act. So now where we stand in Rajasthan is that the act is there in a kind of limbo. The rules haven't been framed yet. And it seems like the current government isn't very likely to start any kind of process to frame the rules anytime soon. But are we upset about it? Yes, of course, we are very upset and disappointed that, we are at this stage. But we are not really hopeless. And I think we are very determined that the kind of campaign that we had put up, and the kind of advocacy that we did in order to make this act happen, an equal amount of effort, campaign, and advocacy, or even more, we'll have to put in order to ensure that, the rules of the act are framed and that those get implemented. And Abhay was very right in his presentation that, we'll also need to build up a wider community movement to raise demand for the act to get implemented. And it's not really going to be very easy. And we also saw it, when during our campaign for the act, it was very challenging, very difficult for us to kind of compete with the kind of resistance and the kind of agitation that the private doctors could build on. There were some 20,000 doctors along with their families and, other supporters on the roads agitating. And we at that point of time could not really build up that kind of, mass movement against the doctors' agitation. And that was, of course, because of our own limitations, resource limitations or whatever. And it has, in general, not really been very easy to mobilize people around health issues. And we're only gradually building up on it. But to mobilize people around health issues has been a challenge. And I think we also need to find out different approaches and different kind of ways to build up, mass public health movements. And that could be something that we could be kind of evolving and learning during this process that we would begin now to advocate for the rules of the Rajasthan Right to Health Act to be framed and to be implemented. But I guess one of the aftermaths of the Rajasthan Right to Health Act has also been that there have been some other states who are now trying to come up with similar acts. I know of Andhra Pradesh, wherein the civil society groups have been very actively working in the state in order to have a Right to Health Act there, and also some other states who are gearing up to do it. So I guess it's a good sign, and it's a good precedent which Rajasthan has set. But I guess things would only matter if the act gets implemented. Otherwise it would just be a piece of paper, and we can go on discussing about it, but it would not really have the kind of impact that it's supposed to have unless it gets implemented on the ground. So yeah, I think that's what I wanted to share, Dr. Jagdishan.
Thank you, Chaya, elaborating in detail your this movement for Right to Health Act of Rajasthan, and very encouraging and positive aspects in the initial years, and the second half, though slightly disappointing. We are still all hopeful since Abhay already put up that broad framework, how to move further forward, and so it is with us. And now it's open for discussion. And Abhay, as you know, we have some questions addressed to both of you. Both of you can, but primarily addressed to Abhay. And so you can start with Abhay. And meanwhile, after finishing these questions, anybody can raise their hands or can unmute and ask questions, and they can go for discussion. We can go up to 9:20 or 9:15, no problem. Okay, to Abhay.
Okay, yeah. So thanks, Chaya, for the comprehensive presentation. And there are some questions in the chat box. So first of all, I don't think it is just a question of me and Chaya answering. There are so many, our senior and even maybe not so senior, but knowledgeable colleagues there on the call today. And everybody will be having, or many people will be having something to contribute in that discussion. So, and the first question, one of the questions is about the Kerala Public Health Act, which was earlier the bill and now it has become an act. And I should first of all confess that I have not really gone into the full details of that legislation, although I am broadly aware of the debates which are there around that. So I will confine myself, and I think that probably Dr. Jagdishan, you, Dr. Iqbal and others are there who are probably based in Kerala and much more conversant about it. Anthony is also there. So all of you who are there from Kerala probably will be in a better position to go into the details. But what I understand is, in brief, is that on one hand, the Act seeks to put in place certain mechanisms for preservation or protection of public health. And towards that end, they have these committees at various levels. They have public health officers and some dedicated additional mechanism to ensure that public health conditions are maintained or they are protected. And that is in itself positive, that it's not just a general declaration, there's an attempt to actually operationalize that through these committees and officers and so on. And probably the earlier Kerala is already building on a much more positive and a better base of public health services than compared to many other states. And as I understand that earlier, probably for dengue and also for the and of course later on during COVID, you had these convergence kind of meetings of different officials from different departments at the district level and even at the state level, which led to better control. So when you have water supply, animal husbandry, agriculture, education, and also health, all these officials coming together, then obviously there's a much better chance that, or much better situation where these kind of public health conditions can be dealt with. It cannot be dealt with by the health department alone, although the health department, of course, has an important role to play. So I think that those are the positive features of the legislation. But I think many of us are aware that there have been serious concerns also expressed about especially some of the provisions which relate to isolation, inspection, and where there is a potential migrant workers, food establishments, etc., where there is a potential where some official is given powers which may be they may be used well, or they might also be not used in a very appropriate way. And we are talking perhaps about more vulnerable sections of society, where traditionally, the state may not always, be fully cognizant of the need for protection of their rights. I'm saying, for example, migrant workers, or maybe food vendors in the unorganized sector. So there is a potential for overreach, and that is something which then goes counter to our health rights and broader human rights framework. So I think there is a need for a serious debate on this, and those aspects of the Public Health Act where there is a potential for overreach or misuse or potential violation of human rights should be clearly reviewed. They should probably be either removed or they should be, recast in a way. Because on the other hand, you do have in Kerala a good system of the Panchayat Raj, and you can have a, so the first measure should not be punitive measures. The first measure should be, what should we say, based on appealing to people, based on collective, reasoning, based on, deliberative action, where people are brought on board. And in most situations, people will respond to that. And you saw that during the COVID epidemic in Kerala, that people did respond to the measures taken by the government on a large scale. So the first measures, rather than being punitive in nature, they should be more deliberative and consultative. And of course, in any society, at some point of time, there may be some people who are indulging in some activity which is detrimental to the larger public health. And despite other, attempts, if they are not, responding and they are putting other larger population at risk, then of course some action will need to be taken. But that should be graded in nature. That should not be, in the form of a, punitive action first. Rather, there should be a scope for deliberative and, consultative processes, even when it comes to public health. So these are just my brief reflections on that point.
There is a question by Veena Shatrutna on AAP's healthcare interventions too, specifically to you, and whether
that's that's another big topic. And right now, probably the topic for today is right to healthcare. So healthcare, public health reforms is a big topic. So there is AP is doing something in Delhi, Kerala is doing something, Tamil Nadu is doing something else, Andhra is doing something else. So that would be a big discussion. Just to put it briefly, I mean, you cannot evaluate a particular healthcare initiative without looking at it in the context of the broader entire health system. Is the only point that I'd like to highlight. So the Mohalla clinics, are they functioning well? Are they treating people? Yes. Are they strengthening and are they linked with the public health system in Delhi? probably not to the extent required. So it's a kind of looks like a standalone first contact care type of intervention. So people do get some good, probably, I mean, generally speaking, reasonable degree of free, accessible first contact care, good. But does that lead to an overall strengthening of the public health system in Delhi? Does it lead to a chain of referral and, overall management of health conditions in a better way? I have my questions about that. So that doesn't mean that we, completely reject it as a model, but it definitely needs to be contextualized in a broader setup. Otherwise, it becomes like a new government comes in, they do something new, which can be shown, and they don't deal with the old problems. They create a new system. So the old problems don't go away. And although Delhi has a pretty good, well-functioning public health infrastructure, not everything is fine even there. There are a lot of things which need to be done there. So that's why this is just my brief comment about the AP.
But I kind of agree with Abhay. If you look at the Kerala Public Health Act, the mandate of the act is very different from the mandate of the Rajasthan Right to Health Act. And I think, one of the person has also mentioned in the chat that it's not really suitable for us to compare the Rajasthan Act and the Public Health Act of Kerala, which to an extent is correct, because like I said, the mandates are very different. But there are certain very good things in the Kerala Act as well. And one of it is that it talks about forming state, district, and local in order to, look at preventive healthcare and to control diseases. The acts like the Assam Public Health Act or the Rajasthan's Right to Health Act, they also talk about similar forums. In Rajasthan, it's called an authority. In Public Health Act of Assam, it's called a board, but they are only until the level of the district and not below it. And what the Rajasthan Kerala's act says that there would also be similar forums at the level of the panchayats, which is great and which we would also have wanted to have in the Rajasthan Right to Health Act, but we couldn't. But the slightly problematic thing, which Abhay also said, is that the tone of the act sounds a bit coercive in nature. Like it sounds like there's some kind of coercion in the way the clauses have been framed. And that's slightly problematic, but like Abhay also said, it needs to be looked at, that, it shouldn't really violate the rights of the most vulnerable and shouldn't be something which causes them more trouble rather than helping them. Yeah.
Okay, then now this session is open. Anybody can raise their hands and give their comments or question. Just since Abhay also wanted me to just add on Kerala Act and all, and agreeing with Iqbal sir, I know when I was in the directorate, this preparedness for revision of this Public Health Act of Kerala started around 2-3 decades back, and Kerala was covered before that. The whole Kerala was covered through 2 acts. One was Travancore Cochin Public Health Act covering AS12 Travancore Cochin area, and Madras Public Health Act covering the Malabar area, which was part of the Madras presidency. So the initial intention at that time, the Right to Health Act, that type of discussion was not there in the area of public health. So the aim and objective at that time was to revise the S2L Public Health Act of this 2 part of Kerala and to bring in a combined act. And so the context of the this Right to Health Act and the revised Public Health Act for which Kerala needs a new Right to Health Act. That's my feeling, and so I'm not elaborating much further. So session is open for everybody to either to raise hands or unmute. And the Anthony already just raised hands, and Anthony, you can start with.
Am I audible?
Yeah, unmute and speak.
Yeah. Congratulations, both Abhay and Chaya. for these two lovely presentations. And while Abhay has painted the overall broad canvas of right to health and right to health care, and quite clear in your presentations, when such a theory is made to practice and a legal framework was drafted by Dr. Narendra Gupta and Chaya, but People's Health Movement in Rajasthan, in the Right to Health Bill, the biggest opponent who spoiled the sport as a spoiled sport was IMA. And Indian Medical of Indian Journal of Medical Ethics had put out a special issue on that, an editorial, and wrote both Anand Fatke and myself had joined a rejoinder on that. And that was in July-September issue of Indian Journal of Medical Ethics. Amar Jasani specifically asked. Now, the thing is, this is a bill which is very historic in Indian Public Health Act, because it has the full legislature, MLAs voted for it and passed the bill. Such a bill was started by 10,000 doctors and families on the street on the sheer two important thing. One is emergency care. And if emergency care is the bone of contention, IMA should be ashamed of it, because they are the duty bearers, they are the providers of a claimant, right holder patients. In trauma, in an accident, they should be giving it free. Now the question is, who will reimburse the cost? There is no clarity, but the whole bill's section 3, C and D clauses there, rules have to be formulated, and it will be clarified under the rules who will make the mechanism of reimbursement to whichever private healthcare or public doctor providing the emergency care. And that still IMA had the guts and audacity to say that it is an anti-people bill. It is not their own self-interest. So I wrote in this rejoinder, is IMA meant to save life or self-interest? This doctors lobby and IMA is started by Dr. B.C. Roy, cardiologist and West Bengal Prime Minister, who wanted affordable healthcare for the poor. And such a, he's the founder of Indian Medical Association. So it's such a shame IMA members, both in the public sector and private sector, coming to the roads and sabotages a bill passed by the people's elected representative of Rajasthan. We have to get it back. We have to form the pressurize for rules and regulation formation, because that has got a role model effect in Assam, West Bengal, and many other states. Tamil Nadu, now Andhra Pradesh is thinking of it. So why not? I think in this August forum, both medical friend circles, People's Health Movement, overall pressure should be there. Cost of emergency care and who will reimburse it is a silly issue. It's a modality issue, but they want to sabotage that thing. The right to health, they don't want either Clinical Establishment Act or a binding legal commitment to any patient in suffering. I'm ashamed of being a fraternity member of doctors if doctors took and moreover, in a grievance redressal system, in that, IMA want a representative. When any of the IMA doctors are facing the court and doctors are accused, how can their representative be in the grievance redressal of a right denied patient? That is a serious issue we have to campaign against. That's my submission. Congratulations, Chaya and Narendra, for taking it forward. Still, you have got a long way to go and fight it out. We are all behind it.
I could not see any hand raising, so anybody can unmute and speak. As Abhay and Chaya rightly pointed out, it's not just restricted to them. All of us should actively engage in the discussion. Please.
Hello, am I audible?
Please go ahead.
Can you hear me? Am I audible properly?
Not very much. It would be better if you just come closer to the mic and continue. So, Saluja, please continue.
Hello. Is this better now?
Yeah.
Yeah. So I'm not really sure if this may not be within the scope, but because there are so many people who have done so much work in the public health movements, I just want to throw out this question of how much is mental health a part when we talk about the larger health systems? Because one, it is still seen as like not as an essential, and because if we see that counseling services still are subjected to GST, so it's seen more as a service than something related with life or essential services. And also again, like a broader thing, but many a times the physical symptoms or physical illnesses are also largely rooted in mental health or mental illnesses. But because these two things are seen so separately, like if I go to a doctor or an orthopedic for my joint pain or some kind of a thing, they're going to continue treating my body, whereas probably like it's not all integrated. So even though this is in the realm of law, legislation, and public health movements, but I also feel that things kind of go to a policy level when they're raised from the ground. So from anyone, not particularly from Dr. Abhay or Chaya, but if anyone has any thoughts on what they think about how it is currently and what we can see ahead when it comes to mental health, is it a part of public health discourse or not? And like, yeah, where are we? Thank you.
Abhay, you can, you just mentioned it as the vulnerable sections, right, as the tribal mental health and all. You can elaborate it if you want.
This is a big topic, and it's
Yeah,
I mean,
yeah.
it requires
But
some
in
detailed
your framework,
discussion.
it was there. It was there.
Yeah, no, but I mean, it's not enough just to mention it. It's a topic in its own right, which requires detailed discussion. Probably, I'm not sure if today we have that type of time,
Yeah.
and so on. So maybe I think Veena has also raised her hand, and she had also.
I'll quickly supplement to that question that we had an entire 3-day session on mental health and the importance of it in Pune. So it is very much to the person who raised the Shastas. The thing is, it's very much in our heart. Community-based delivery of psychiatric mental health services is very important. And the sheer deficit of doctors, psychiatrists in the country shouldn't be a roadblock, and we must develop paramedicals to handle many of the things down sub-district level. That's all I got.
Okay, now let us go to Veena.
Thank you very much for this opportunity. I really find it fascinating when we lay out a roadmap for healthcare for all in whichever format, with or without the private sector. But given today's world, where there is such a mess in every corner of the country, it's not just Ayurvedic doctors, Ayush doctors intermingling with modern medicine doctors who initially protested, but now are using cheap labor in the nursing homes. You go to a nursing home, the Ayush doctor is there who is not even able to take a blood pressure or dress a wound properly. There is private, public, there are small hospitals, big, and the corporate hospitals are unimaginable. They are larger and more confusing than government hospitals used to be. Where does one start working, Abhay? If I had to put my finger on one area, they all need to actually be working towards the health of people. But each one is a law unto himself. And I'm not even talking about Ramdev's magic cures. I'm talking about serious people on the ground, there to make money. Corporate hospitals have their targets. Small nursing homes are closing down. All the DIs have been de-skilled in a most sad way. Where would one start putting brick by brick a new system in place? I mean, it's like a utopia that I can't, maybe my next janma, but where would one start?
Yeah, so Amina, I mean, again, all the points you've raised are very valid points. And but I mean, I'll just come to your last point. Where should we start? I would say start where the people are and where people are willing to come together on health. That is, in my understanding as a health activist, that is the most appropriate starting point. We can critique, analyze, describe the situation from national to state to what are various levels and corporatization, all that we should keep doing that. But in terms of action, wherever people are seriously affected by deprivation, denial, or exploitation in healthcare, and there is some kind of existing social formation, it may be some existing social group which has not worked on healthcare earlier, it may be some Jan Sangathan, it may be some women's group, it may be something else, who are willing to take up the issue of healthcare. That is where basically that's the best place to start, because there at least people will come together and will raise issues in some effective manner. And that's something that, I mean, we tried to do in Maharashtra when we started working with people's organizations on health issues, organizations which had been working on forest rights, land rights, displacement, etc. And till today, that is essentially the effort that we have been making. So as I probably briefly shared, that before the Vidhan Sabha elections, we have now started a process of trying to formulate what are the issues which affect Adivasi communities in the health sector. Now, why Adivasi communities? Because there are already a large number of organizations working there. They have a range of serious healthcare issues, and there is some potential for social action to emerge from there. Or the same may be true for example, solid waste, management workers, Safai Karmacharis, across the country and across Maharashtra. They are mostly Dalits, and they have the most hazardous and unhealthy working conditions, and most of them don't have any kind of basic healthcare security. So why not, and there are unions, there are organizations. So why not work with these kind of groups, and where the starting point would usually be primary healthcare or, the healthcare which people, frequently access. That is where, there's a better chance of being able to develop a social initiative around healthcare rights or around health rights. That is my just general session. So it's not such a hopeless situation. In fact, there are so many things to be done that you can start anywhere and you'll get some positive response. People need actually positive interventions in healthcare. So if something is done which is has some chance of being effective, people do respond. It's not like that. So I don't know if I have answered your
Madam,
question.
you just started your video and we could see you. That was good and nice to see you, madam.
Yeah.
So
I just like to add 2 sentences on the mental health issue, because it's a big topic, so we don't have time to discuss it. But I'd just like to say that there is a relatively limited issue of mental health care and services for mental health, which is very important because the situation there is very, very abysmal right now. And there is also a broader issue of determinants of mental health and why people today, I mean, we saw it in COVID in a more exaggerated form. So isolation, stress, various kinds of other, factors which are leading to suicides among students and farmer suicide and various things, which are multifactorial, which are influencing people's mental health, and which is probably the situation is in some ways worsening. So that needs a very different kind of approach. That is not something that a psychiatrist can deal with or even a psychiatric health service can deal with. So we need much better psychiatric care, especially in rural areas and for poorer sections of the population. But we also need a very different kind of thinking about what is the situation of mental health today in a broader sense. And all of us I mean, I'm saying this with little bit of, exaggeration. Maybe all of us have mental health issues of some kind in some form. It may be just, frequent stress about things or whatever. So it's also a broader issue. Just a additional point.
Abhay, just one comment to your during your presentation, you mentioned about the this social audit concept, which was to some it was put up by the NHM and the scope for exploring the scope for, and I don't think it has gone any further. And in our place also there was some discussions and the scope for developing a systems for social audit at lower levels, and but that doesn't succeed. I don't know what was your experience and in your place, and but I think my feeling is that something coming from the higher levels. Of course, the authorities, they will always try to incorporate whatever new ideas, newer community-based these things coming up. They'll try to incorporate it, but there is a need to raise these issues at the grassroots level and from the people's side, and then only it would be a meaningful type of intervention. Social audit, always there was a discussion in Kerala for last 20-25 years in connection with the decentralized planning. That also never succeeded in. So just I was thinking of your that concept you mentioned as part of your broader framework and the scope for NHM.
Yeah, so Dr. Jagdishan, for something to succeed, it has to be attempted properly. If it is attempted in a very half-hearted, diluted way, it's bound to fail. Okay, so community-based monitoring or social audit, there are outstanding examples in our country. The social audit of NREJ in Andhra Pradesh and Telangana is one example, and community-based monitoring of health services in Maharashtra and a few other states also in the initial phase. When there was some political will behind it, at least in a broad sense, did lead to significant positive results. But once the central government, especially after 2014, completely lost interest and, lost interest in NHM, what to say of community monitoring, which is a small component of NHM. So once from the top, the political will evaporated and completely different kind of priorities came into place like Ayushman Bharat, etc. This got completely pushed to the margins for the state. So despite that, the fact that it has survived in some form is itself quite remarkable. So when it has been attempted properly with sufficient support, it has proved to be effective. If it is attempted in some half-hearted or diluted way, then perhaps it may not, like anything else, it may not work very well. But it has huge potential to enable people to reclaim health services at the grassroots level, to make services accountable, and also to participate in the planning process. Now in Kerala, because you already have a strong panchayat system and a different kind of history, perhaps here it will have to be thought about in a different way. It will not work in the classical way. But in most other parts of the country where there is almost no local participatory mechanism for people to participate in any kind of governance, there a social audit mechanism or community monitoring mechanism definitely proves of added value. This is my hunch. So don't
I do fully agree with you.
Yeah.
I'm not against the concept of community monitoring or community-based monitoring and planning. Planning to some extent we succeeded in Kerala, but monitoring, I don't know too. But of course, media and community protest and all is happening. So anybody, any more questions, any more comments, discussion? Now it's 9:15, almost. We may take a few more minutes and then we will have to conclude. And so anybody? I think nobody's raising their hands or nobody's unmuting. So let us conclude it. For me, it was a very, very good session. And so in fact, the discussion which we were having in many other sessions are coming as an action point coming to this this session for me, since there is a need for bringing in a right to health movement in the country and in every state and in even every local region. Then only we could achieve the our objectives. And so this would be a very important session, and many of the elements which came in as part of the discussion will be further continued in coming sessions and in the offline session, which is going to happen on 10th and 11th at Code. And I would like to inform you all that the registration for the offline session, that is 10th and 11th session, is already started, and it is in the WhatsApp group, and the Google link is available in the WhatsApp group, and email group also it is available. And so next week at the same time we will meet, and we'll have a session on climate change and health, in which Soumya Swaminathan and Tejas Jayakrishan and 2 speakers are there. And after the next week we have a session by Imrana Kadir, and then we go for the offline session. So let us conclude. Good night, everybody. Thank you for the presentations and the discussions. Thank you very much, Abhay and Chaya.
Thank
Okay,
you.
thanks.
Thank
Bye.
you. Bye. Good
Bye.
night.
Good night. Good night.
Thank you, one and all.